stress syndrome. Her presentation, Pediatric Emergencies and Airway Management, will cover these objectives. Now we'll turn it over to Dr. Wellnitz. Welcome, Dr. Wellnitz.
Hi, thank you so much for letting me be here. I'm going to start sharing my screen and let me know if there are any issues. And can everyone see my slide? Whoops, I'm going to fix this. All right, can everyone see my slides without the presenter view?
Looks great.
All right, wonderful. Well, thank you again for having me. So my disclosures, in addition to what Ms. Peterson mentioned, I'm also the pediatric specialty team co-lead for the Region 7 DHRE. I'm also a subject matter expert for the Pediatric Pandemic Network. And if you're ever in need of excellent pediatric resources, I would highly recommend going to the websites of these two different organizations. There are tons of things related to just management of general pediatric patients, and then also pediatric surge and disaster considerations. And so we have already sort of laid out the objectives. And basically, the goal of my presentation today is to help you discern sick versus not sick and be able to recognize what some of the key initial steps are to stabilizing patients that you see with common diseases such as asthma, bronchiolitis, croup, and anaphylaxis. So many people, including pediatricians, find kids to be challenging to assess and appropriately care for. It's especially hard if you're coming from a background where you're dealing mainly with adults. So one of the things that's important is when you are working with children is to know what's normal and what's not normal. And so as you can see, as children age, they go from having a respiratory rate where breathing up to 60 times a minute can be normal and healthy to when they're adolescents breathing more in the 12 to 16 that we'd expect to see in adults. There are also some important anatomic differences between adults and kids that will impact how you care for them. For example, children have narrow nostrils, and as newborns, they're obligate nose breathers. This can be huge in terms of if a child gets an upper respiratory tract infection, they may end up benefiting more from suctioning than you would necessarily see with an adult blowing their nose. The head is rounded and often relatively large in proportion to their body, and so sometimes special adjustments need to be made in positioning for bag mask. Additionally, the tongue is large, and there are also other structural differences in the airway further on down. And so with the large head and the short neck, positioning is key to be able to adequately bag mask your patient and to insert an airway. Many times for young children, it's important to put a shoulder roll behind them in order to appropriately line up your oral, laryngeal, and pharyngeal airways. The children's airways also have a smaller diameter than adults. And this can be especially important when you think about the impact of just having 1 millimeter of edema. As resistance is proportional to the radius divided by the fourth power, just that 1 millimeter of edema in a kid can lead to a 16 times increase in resistance and a 75% decrease in your cross-sectional area. So small changes matter in these small children. With the larger tongue and the higher anterior larynx, it can be quite challenging to adequately obtain a good view for kids. So the tongue can obstruct the view and the airway while you're trying to intubate. And so you may need to use an oral or nasal airway during bag mask ventilation. It's also important to use the blade to sweep the tongue out of the way. And then when you're lifting up to intubate, you don't necessarily rock back and forth, but it's important to sort of lift up and pull back at a 45-degree angle. Cricoid pressure can be very helpful with anterior airways, bringing it into your field of view. And for young children, using a straight blade can also be helpful in terms of dealing with their specific anatomy. There are a number of physiologic differences that make kids a little bit more complex to deal with as well. So as I mentioned, newborns and infants are obligate nose breathers. So sometimes if you see a bronchiolitic come in, working really hard to breathe, a first step can be just to suction the child's nose, and that can be a huge game changer. It can sometimes, I've seen it sometimes decrease the respiratory rate by about 20 when they finally calm down from being suctioned. Children's chest walls are also more compliant and the ribs are more horizontal. And so what that means is the muscles of respiration have to work harder to facilitate gas exchange, and the children may be more prone to tiring easily. Lastly, the oxygen consumption rate in kids is about twice of that of adults. And there's also less alveoli for gas exchange as your lungs continue to develop into your 20s. As a result, hypoxia develops more quickly. And then a big key take home point that I think is critical to remember is that infants' response to hypoxia is bradycardia. And bradycardia can set off a chain of bad events that can lead you to cardiac arrest. So as infants' cardiac output is mainly dependent on the heart rate, they have a limited ability to increase their stroke volume. Having that heart rate go down in the setting of bradycardia can set you up for a cardiac arrest. So it's important not to sleep on hypoxia. And if you notice a kid's heart rate going down while you're assessing them and caring for them, it's important to step back and ask yourself, is their heart rate going down because they're responding appropriately to the interventions I've done, or is their heart rate going down and they're looking worse? Then it's ready to get. Then it's a good idea to start to get ready for the next steps in management. It's also a reason why if you are trying to intubate or place a supraglottic airway, you should have a low threshold to stop trying to get the airway in, pull it out and bag if you start to see that saturation drift lower and the heart rate drift lower. So as the great Yogi Berra said, you can observe a lot by watching. And so we're going to go over some of the most commonly seen signs of respiratory distress in children, talk a little bit about their physiologic purpose, and then sort of talk about how you integrate that all together in your assessment of a child in respiratory distress. So first, we're going to be talking about tachypnea. And then please let me know if the video is coming across appropriately. So tachypnea is a child's first attempt to compensate when they have inadequate gas exchange. So the first thing they'll do is try to increase that respiratory rate. Since infants are already breathing at a pretty high lung capacity, they can't really like increase their tidal volume in order to maintain minute ventilation. So they'll just pick up their breathing rate. Um, and so often early on in illness, you'll see a child that has tachypnea but otherwise looks pretty comfortable. Um, and so you may notice that over time they may add on these other different respiratory findings indicating that they're tiring out. And so breathing this fast does use quite a bit of energy. Here, let me advance the slide. Um, onto nasal flaring. Oops. Oh. So nasal flaring is a way to increase the size of the upper airways. And as you can see, this little guy is doing that to just try to get a little bit more air moving on in. Oops. Okay, on to retractions. So retractions are a collapse of soft tissue because of muscular effort. It's just another way that infants and children are trying to increase their tidal volume. Young infants have very compliant chest walls, and so you may end up actually seeing retractions like around the sternum. Where you're seeing the retractions can also correlate to the level of difficulty of breathing that the child has. With mild to moderate respiratory distress, it's common to see substernal, intercostal, subcostal, where as the child's respiratory distress advances to severe, you might see the supraclavicular, suprasternal, and then those sternal retractions that we talked about. Onward to grunting. And so grunting is breathing against a closed glottis to sort of give yourself some of your own PEEP and keep your airways open. As you probably noticed, it's an expiratory noise and it tends to be a little bit deeper pitched. Um, let's move on to seesaw breathing. So in seesaw breathing, a child is using abdominal muscles to forcibly exhale. It's something that you'll often see with lower airway obstruction, and you may find in children that have bronchiolitis and asthma. Head bobbing tends to be a later sign when a child has been working quite hard. They're still using their accessory muscles to help them breathe, but they are becoming so tired that now their head is bopping around while they're doing it.
Dr. Wellnitz, we can see your video, but we cannot hear it.
Oh, I I apologize. I am so sorry.
You might have to
Um,
give your best impression of what
okay.
it sounds like.
Um, okay, this will be interesting. You could see that he was head bobbing. He was also sort of grunting and wheezing at the same time. Um, last that we're going to talk about is stridor. And so I'll play this so you can see the work of breathing. I'll do my best impression. Don't hold it against me. So it's sort of a sort of noise. And this is common to see in upper airway obstruction, such as croup. Now that we've looked over some of the common findings in kids that are presenting with respiratory distress, the important thing is to integrate them with your whole assessment of the patient. So the big things to consider when you're thinking about sick or not sick are the child's appearance. Do they have appropriate muscle tone? Are they interactive with their family? Can they be distracted by like playing in a toy, watching Bluey? Are they talking the way that you would expect? In terms of circulation, um, circulation in terms of like their coloration can be huge. You won't often see cyanosis until kids are down into like the low 80s, and so that tends to be a bit of a late sign. And then lastly, we've already covered sort of the breath sounds and other findings. So when should you get ready for the proverbial things to hit the fan? So you might think that you might notice that you're starting to get a bad feeling about a kid when their air entry is impaired. You're listening to their chest and you're not really hearing much air movement, which could be due to shallow respirations or it could be due to pretty significant airway obstruction. Also, if you've escalated their support appropriately and they're still satting in like, let's say the mid 80s, despite being on high flow with a high amount of oxygen supplementation, that can be a sign of a impending respiratory arrest. Um, as as children evolve within your care, again, if you've noticed their respiratory rate dropping off, that may be a good thing. It may show that they're responding to your therapies, but it also may be a sign that they're tiring out. children that are under 3 months old in particular may present with apnea in the setting of common viral illnesses. Um, then never underestimate the power of skin perfusion and color in giving you some additional information. Sometimes you'll be assessing a kid for a first time. You'll walk in the room and you'll be like, well, their respiratory rate looks okay. Their heart rate isn't too terribly bad, but they just kind of look like they have gray undertones. I'm getting more and more worried about them. And then level of consciousness. So early on, when kids are struggling with respiratory distress, they can become quite agitated, difficult to console. And so if you notice that child who is initially like, oh, wow, they're just crazy, can't get them to hold still, except like even blow by, they're now just kind of like laying there on their mom, that can be a very dire sign that they are heading in the wrong direction. And we've already talked about the significance of bradycardia. Um, and so I'm just going to present two different videos that you don't necessarily need to hear the sound for to sort of discuss how we're putting them together in terms of sick or not sick. So looking at this little guy, you can see that he is definitely tired appearing. He is laying against his mom. He also was having some pretty significant retractions. I'm just gonna, um, pretty significant retractions. He uh, is not really opening his eyes. And another sign that we didn't talk about was sort of guppy breathing, where they're sort of like opening their mouth like a little fishy, trying to get in extra air. So that is definitely a sick kid. And then uh, the title of the video gives it away, but this kid's color is not the best. You can see that the ophthalmologist that was examining him was poking and prodding him and not getting much of a response. And he was just laying there sort of listless. And so, um, and so I feel like these were two pretty straightforward. Oh, yes, they're definitely sick cases. The hard part is in that gray area where they don't necessarily look like a kid that you'd expect to be just, go home playing, but they're also sort of in the middle. And that's where experience, time, and frequent assessment, also talking with your team members, will help you decide where you think that child is in their illness course, and what you think the next steps need to be. So when we're thinking about respiratory problems, it can be helpful to talk about what the actual underlying issue is. Is it a neurologic control of breathing problem, such as if they have increased intracranial pressure? Is it a lung parenchyma problem, like pneumonia? Also, or is it something that may be an upper respiratory tract problem like croup, or lower respiratory tract problem like asthma? And so we're going to just go through some of the more common things that we see in children. So croup, the long fancy name is laryngotracheitis, which describes where you have that inflammation. You have it in your larynx and your trachea. And so this usually occurs in the setting of a viral infection. The classic teaching is paraflu, but you can see it with RSV, you can see it with COVID, you can see it with rhinovirus. And the key features are inspiratory stridor, hoarseness, and this classic barky cough. I'm going to show the video and try to do a really bad cough. Here. It's sort of like, uh. One of the other things is, and I tried to include the links to the videos in the slides. If not, I can send them out to the coordinators so that if you want to look at the videos with the sound, you'll have access to them. But so with croup, uh, there is the famous Wesley Croup severity score. Now, I don't expect you to know that. It's just to give you sort of a sense of like things that you should be looking out for and how bad it is. And so a kid that comes in with mild croup, they may just need to have their fever controlled and get a single dose of Decadron. But if they're a kid with moderate or severe croup, then their parents may be calling EMS. Doing a single dose of Decadron, either PO or IMIV, can be incredibly helpful. And as in addition to using racemic epi. With the racemic epi, you can give repeated nebulized doses until you get them to a good, either get them to the hospital that you're taking them to, or get them to, example, from the ED to the floor. So one of these things with the kid, one of the classic things as pediatricians we learn is that sometimes you approaching the child and making them more anxious will lead to an increase in their respiratory distress. Obviously, you need to manage them as appropriate, but if you can use their family members for reassurance or other things for distraction, that can be a huge thing in preventing them from going further down the pathway. As with other causes of upper airway obstruction, these are the, oh crap, don't intubate outside of a place where you have good experience with pediatric airways. Often even in the pediatric ICU, we'll ask our anesthesia or ear, nose, and throat colleagues to come and assist with a croup kiddo that has impending respiratory failure with the signs that are listed here. Asthma exacerbations are very common and are due to inflammatory disease affecting the lower airways. So hallmark is a bronchospasm and reversible airway obstruction. You'll commonly see it in kids after a viral infection or if they're exposed to an allergen. When I lived on the West Coast, every time there was a wildfire, we always got a bolus of kids coming into the ED in the coming days with a new exacerbation set off. Similar for how you're assessing your other kids, how much are they speaking? Can they only get out like a word, or can they speak in full sentences? Sometimes if you ask the kid to say the ABCs and you see how many letters they can get through without needing to sort of gasp and take another breath, that can give you a sense of how much they're working. How alert are they? Are they having significant retractions and forced exhalations? How is their wheezing? Are you hearing wheezing throughout, or are you hearing very little in terms of air movement? Due to the wide swings in intrathoracic pressure while they're breathing, they can have pulsus paradoxus. Sometimes this finding can disappear as they're about to crump. And then also, what are their saturations doing? And if you have the ability to run an I-stat or check a CO2, that can also be helpful in sort of giving you a sense of their tempo and how they're doing. And so similar to some of the other red flags we've talked about, if they were super tachypnic, now they're just breathing pretty slowly. If they are now confused or drowsy, and then the most ominous thing is if they have a silent chest. So silent chest, like you were hearing them wheeze, you expect to hear a wheeze because of their disease pathophysiology, and you're not really hearing air entry at all. That can be an oh crap, let's get ready for stuff to get real sign. So in terms of asthma management, I feel like a fair bit of it is similar across kids and adults. So for mild to moderate, you support them with oxygen, do intermittent doses of albuterol, and then add in some PO corticosteroids, such as Decadron or prednisolone, or whatever you have most convenient. In terms of moderate to severe, you advance your respiratory support with what you have available. Do you have high flow? Do you have a non-rebreather? You may need to use continuous oxygen or continuous albuterol, or if that's not available, do back-to-back nebs. If you happen to have Atrovent on hand, also working that in as well. And then with their degree of respiratory distress, it may not be prudent to let them continue to eat or take stuff by mouth. And so giving them their steroid IV could be something that's helpful. If they have severe to impending respiratory failure, consider giving IM epi. Terbutaline is something I personally love, but I know it's not very widely available outside of the ICU, and sometimes waiting for it at a referring facility can just delay important transport time. You can also consider BiPAP. These kids, these kids, because they are doing such a huge, like, because of the wide swings in intrathoracic pressure, the fact that they're dehydrated from working so hard, usually, they are at high risk of having cardiorespiratory collapse when you try to intubate them. And so these are kids that you will do your darndest to try to avoid putting a tube in. Bronchiolitis is one of the most common pediatric illnesses, and also can be one of the most frustrating ones because it's mainly supportive care. You tend to see it tends to start with like upper respiratory symptoms, rhinorrhea, like they can have like goopy eyes, that sort of stuff. And then it's followed by lower airway symptoms, wheezing, crackles. You may have heard the classic description of musical rhonchi, and it really does sound like someone is sort of playing, just sort of mashing on an organ. It's almost always due to viral causes, such as RSV, and occurs mainly in kids under 2. Um, Bronchiolitis may or may not present with a fever, and if it does, that fever can add significantly to the child's work of breathing, and offering an antipyretic can sometimes help decrease their help bring the fever down, and through that help with their work of breathing while you're doing all of your other supportive measures. As I mentioned before, young infants may present with apnea associated with their bronchiolitis, and in between their apneic spells, look like they're doing okay, but obviously need to have that apnea addressed. So the typical course for bronchiolitis is that there's sort of like a warm-up phase over like days 1 to 3. It tends to get worse and peak on day 3 to 5, and then it usually rapidly resolves on days in the coming days. And so it can often be when you're assessing a kid and trying to figure out, okay, where are they in their disease course? Like, do I expect it to get worse, get better, stay the same? It can be helpful to ask the parent when they started to have symptoms. This is just a rough rule of thumb, but it can be helpful if you're like, well, do I need to take them to a place that has a PICU, or do I need to take them to a place that just has a pediatric floor? And so supportive care is key for these kids. So get those goobers out of their nose, keep those upper airways open, make sure that they're adequately hydrated. If their respiratory status is such that you don't feel comfortable with them taking stuff by mouth because you think you might have to further escalate their support, these are good kids to get an IV in, get your fluids going, even when we're in a situation of IV fluid shortage like we are now. Offer supplemental oxygen is needed. And then, as I mentioned, control fever. There is a limited role for bronchodilators and steroids in this disease process. Uh, so, and so one of the things, um, one of the things that's challenging is, yes, you hear wheezing, but and it may be appropriate to do a single trial dose of albuterol, but you have to like carefully assess them before and after to see if you actually think it's helping, or is it just making them tachycardic and pissed off? Then anaphylaxis. And so anaphylaxis, we typically think of hypotension and then upper airway symptoms, but it can also just be skin changes like angioedema with GI symptoms. And so it's important to sort of have a broad a way of recognizing it. One thing to note is if the parents have already given them like their home EpiPen or given them an antihistamine, they may not have like the full complement of symptoms that they were having when you see them. And so you really have to get as much of that history even in like very compressed time you have there. Um, like you guys know, you try to remove the allergic trigger if it's still possible, and support their vital signs. IM epi is your friend, and it's what's going to fix the problem. Steroids will help, but IM epi is going to fix the problem. One thing that's important is that never give the IM prep of epi through an IV or IO route. You'll cause severe tachycardia and pretty significant strain. And then unless the child is in extremis, in like extreme extremis, don't give IV epi for like initial management. You can repeat the IM epi every 5 to 10 minutes as needed. And it's one of those things where like if you're thinking about giving it, just give it. I like this algorithm because it sort of walks you through stepwise what you should be doing. So as you guys know, place that IV, give them a bolus of IV fluids, start giving them some supportive care. If you're having to give them multiple doses of epi, consider starting an epi drip. If continue giving them boluses until their perfusion and blood pressure stabilizes, and then keep on going from there. And then in terms of like, well, let's say you're like, oh my gosh, I just picked up this kid. I don't know what their weight is. They look like they might be 20 kilos. So up to 20 kilos, you can do the dose of an EpiPen Junior, which is 0.15. If for weights above that, you could start with 0.3. And so in terms of initial respiratory support and airway management pearls, so I recognize that every EMS system is different and and the tools, resources, and experience of providers, experience of team members varies dramatically from site to site. And so I just tried to keep this rather broad and hopefully applicable to everybody. And so suctioning and positioning can go a long way. If you are able to get a child to calm themselves without using medications in order to accept whatever respiratory support you're providing, that can be a game changer. If you think that you do need to use sedation to get them to, for example, to tolerate a BiPAP mask, make sure that you're doing it in as controlled of an environment as you can, and that you are monitoring them appropriately. Also, acknowledge your skill sets, the things that you do awesome, and then also the things that you know are areas to work on. Sometimes if you're able to bag mask ventilate a kid, see good chest rise, keep the SATs up, sometimes that might be the thing that you need to do while you're getting the kid to the hospital instead of having multiple failed airway attempts leading to repeated rounds of desaturation. It's hard. It's hard to do, but if you're able to practice either through simulation, through going to your local children's hospitals, those sorts of things, just seek out the opportunities as much as you can or are able to get that additional experience. And then also know your local resources. So who in your transport team is a good resource? Who is someone that is awesome at the airway at your local hospital? And then who can you call if you're like, hey, I want to bounce an idea off of you about medications to use or that sort of thing. And so I found this algorithm to be incredibly helpful. So this is by a gentleman who's an anesthesiologist at Tufts, and is talking about how to get the pesky infant or toddler appropriately positioned for bag mask ventilation. And so it's a 3-step process. And so the first is to get your forehead and chin horizontally aligned. The second is to open up the neck and get it wide and open. And the third is to get your sternum lined up with your external auditory meatus. And so as you go through these steps, you may find that the kid is that just doing simple head extension gets everything lined up the way you want it. And so for some children, this may be all that you need to do to get them in an appropriate position. But if you extend their head and you notice that their chin and forehead are not horizontal, that their neck isn't fully open, then you will want to proceed to the next step, placing a shoulder roll. So again, so again, they placed a shoulder roll here, and they're going to have you in the next step put a little roll underneath, a little, what's the word, pillow underneath the head. A lot of times, if you notice that you don't have everything lined up the way you want it, sometimes just take out some of the blue towels, make it just a smaller shoulder roll, and it'll be in a good spot. If not, you can add a headrest until all the criteria are met. And then once you've done this, you should be in a good spot to be able to adequately bag the kiddo. And then this is just another example of doing this for a kid. A lot of times you don't necessarily need to have that shoulder roll in older children who have less of a large head size. And so depending on whether your scope of practice includes intubation or doing a supraglottic airway, if it's something that you are going to do, make sure that's something that you absolutely have to do, and that you can do it in as safe a fashion as possible. So the person who's putting the tube in should ideally have some strong experience doing it on a relatively frequent basis, so that they can feel confident in their skills and make the other people around them feel confident. It's impossible to control. It's something to work for in terms of controlling your environment. And by that, I mean minimizing distractions, minimizing competing priorities, making sure everyone has an assigned role and everyone has an assigned plan. Like, okay, well, if the stats hit 85, we're going to pull out and bag. And then also talk about like what emergency drugs do you need? Do you think that is this like a really young kid where you think you probably need atropine? Do you want to give it off right off the bat, or do you want to give it only if you think you need it? And then and then talk about like, do you have a bailout plan? If we don't get it after so many attempts, what do we do next? Is it a kid that we've been able to bag easily and we're like, okay, that's fine. We'll do it try 2 or 3 times and just do it. Or is it a kid where you're like looking at the kid, maybe an obese teenager, and you're like, I don't know if we're going to be able to help him by bagging. And so some additional intubation pearls. You guys have probably all seen the Broslow tapes that can help estimate what size equipment and medication doses you need. And so the key thing is red to head. So have that red tape towards the head. In terms of figuring out what size endotracheal tube you need, the general rule of thumb is for a cuff tube, age divided by 4 plus 3.5. A cupped endotracheal tube can be really helpful if you're needing to deliver higher pressures in order to adequately ventilate and oxygenate the kid when you're bagging. If you put in an uncuffed endotracheal tube, all that air is just going to go on out around. In terms of your oral airway, you just sort of measure from the angle of the mouth until the angle of the jaw. It's important, don't put it in awake patients or kids that are like moderately awake. If the kid is not adequately sedated, they're going to puke on it. And then for your nasopharyngeal airway, measure from the tip of your nose to your earlobe. There's always a temptation once you get the airway to just sort of jam it as far in as you can get it because you're like, I got it, I'm not losing this. But a good rule of thumb is to intubate to a depth that's about 3 times the endotracheal tube size. And so know what equipment you have. Every so often review it, is just so you have a general sense of what you would grab in an emergency. And then also sort of think about, well, what would I want to do? And so I know I tend to talk a bit on the fast side, but thank you so much. And I'm happy to take any questions.
Okay, this is Vicky. There are tons of questions for you.
Okay, and I will do my best to answer. And if I don't know, I will tell you and I'll look it up and email Vicky and she can send it out.
Perfect, perfect. Okay, first question. In regard to endotracheal tubes for neonates, would you confirm that it is best practice to use cuffed ET tubes for neonates only? I'm not sure if that question means only cuffed for neonates or cuffed only for neonates and uncuffed for other kids?
So I know that our NICU tends to prefer uncuffed endotracheal tubes for neonates. Um, uh, we in the PICU, depending on what the kid is coming for prefer cuffed. But in general, most NICUs prefer uncuffed. Just because there's a lower risk for damage. If you're able to adequately like ventilate and oxygenate the kid through an uncuffed tube, that is ideal because you're at less risk of causing damage that can lead to subglottic stenosis. But I would also, if you have a hospital you tend to transport your kids to, I would also ask them what they prefer.
Absolutely. That's definitely an argument for training together, EMS and hospitals together so that you're on the same page with that. Next question, can you provide a recommendation for maximum PEEP that would be safe to administer in the pre-hospital setting with the RAM cannula?
Yes. So in general, we tend to sort of say if you're getting above a PEEP of if you're getting up to a PEEP of 12 and the kid still looks like crap, that is usually a sign that you need to start thinking about putting in an airway or switching over to a different interface, such as one that covers the nose and mouth, which I know you may not have. Um, and so and so it's a little bit experience and experience dependent. There, if you've and so it's often good to like start with sort of like if you think that they need to be on CPAP, and you're just having to sort of arbitrarily pick where to start, starting with like 6 or 8 is fine because then you have room to go up or down. You want it to be enough that it provides them support to keep their airways open, but not so much that they are working excessively to breathe against it, if that makes sense.
Mhm. Absolutely. There's a question slash debate about using CPAP on kids. Iowa actually in the scope of practice for paramedics does not allow CPAP
Gotcha.
for
Okay.
kids under, I believe, under 12, under 13.
Okay. And is that CPAP even if it's delivered through like a nasal interface?
It says, okay, I'm looking at the scope of practice, BiPAP, CPAP for adults 13 years of age or older is just, that's all that the scope
Okay.
said. Other states likely are different.
Gotcha.
Okay, here's another. When you run across a patient with patent ductus issues, are you still allowed to give oxygen?
So this is one of those times where it helps to phone a friend because it really depends on with the patent ductus that's open. Is it just open because they're premature, or
Mhm.
is it open and they have ductal dependent systemic circulation?
Mhm.
Um, in general, if you have a kid with complex congenital heart disease or a ductus, like a lot of times we will recommend providing flow first, and seeing if the flow helps bring your saturations up if that's the concern, and then gingerly titrating the oxygen. It's one of those things where it's so patient dependent. If you know you're taking a kid to a referring facility and you can talk to one of the providers there, that can often is the safest thing to do.
Yes, yes, very good. There's a lot of really specific questions and tons of interest here. Many EMS services do not carry racemic epi, and for those who don't, what would be the dose and concentration of normal epi?
And I guess my question is, are you talking about epi for nebulization, or are you talking about like giving IM epi instead of a rack epi? Would be my question.
That would be my
Because
question as well. Mason, if you can put it in the chat. Nebulized normal epi.
Um, so let me, I can look up the specific of that. 1 second. Um, I can look up the specific of that and get back to you.
Sure.
it's one of those things that I'm blessed in the hospital to have just ask for it and get it, but I realize that's not a universal thing.
Sure. And, it's always the normal reminder that we all follow the protocols of our medical director, whatever they might be.
Exactly. And so it may be the protocol in your system to just provide oxygen. It may be to try using albuterol instead if you don't have rack epi. It's totally whatever your medical director and your protocols say.
Sure. Next question. In Chicago, we don't have racemic epi or Decadron on the ambulance. So what would you recommend regarding regular epi, albuterol, and Atrovent? I think Atrovent is what that
Yeah.
is now.
So if you I think that I need to look up how you would dilute or make regular epi something that you could give as a neb. If that's something that is part of protocols, you could definitely try albuterol. Again, I would really like sort of rely. I don't want to tell you anything that'll get you in trouble. Those are definitely some things that you can try and are reasonable to do. Mainly the albuterol, because the ipratropium more like deals with like the airway secretions, but yeah.
Also, if I could just chime in, I want to make sure all of our folks can hear this information. So we are going to compile all these questions and answers, including the ones we don't get to. So Dr. Wellnitz, you'll also have time to address any of those like really specific nuances, and we'll be able to push that out to our attendees. And so I just wanted to make sure.
Oh, awesome. Okay.
Yeah.
Because now I'm curious and I want to know
No,
too.
exactly.
So yeah.
We all get to learn together. And I thought we kept hearing that question a lot. And I was like, let's just share this live so that everyone kind of hears, like, as you have questions tonight, anything we don't get to or anything that needs deeper diving, our experts always dive in for us and share that info back. And we'll be compiling it, sending it out in an email to you guys, as a follow-up. So that'll be great. Please keep the questions coming. Vicky, if you're okay, could I share the instructions with Dr. Wellnitz about how we could possibly play a few of those videos with sound real quick?
Sure.
Oh, yes, please.
Awesome. Okay. We're doing a little technical support, and please be patient with us. None of us are tech gurus, but Dr. Wellnitz, if you can stop sharing your screen, I have a few steps that may allow you to show maybe like one or two of your most favorite videos that the sound is really critical. And I think that will help with some more of those questions. So if you click start sharing screen, you then need to select share computer sound in the share window. It's a checkbox.
Oh, okay.
Yep.
You'd think after close to 4 years of Zoom, we
Nope.
would sort of know.
It's okay.
But
This happens to everybody, myself included. We use Teams and we constantly forget to hit the toggle. So if you want to try that, let me know if you see it.
okay. And do you see the big slide that says thank you again?
Yes, we do.
Okay. So I'm just going to scroll backwards. So I think the one that was key was croup.
I'll let you know if we hear it.
Here, I'm just going to forward it, okay, to where it actually starts.
You can hear it. Thank you.
Yeah, and so you can sort of get a sense of like what that barky cough is like. And then let's see. Whoops. And then the stridor, I think, was the other one that was key. Thank you so much for suggesting it. I feel like the sound, for some of these, like the sound is key for.
That came out perfect. Yes, thank you. We had a lot of folks asking if they could hear it. And then as just a quick reminder too, the presentation is going to be shared out with everyone who's in attendance tonight or that registered. And we'll also pull those links to those videos so you can listen and share with your colleagues. And I'm going to hand it back to Vicky for any relevant follow-up questions, but thanks for sharing those videos.
Very good. That is the sound that none of us wants to hear ever. Let's see. Oh, a clarification. Did you say pulsus paradoxus goes away just before a arrest?
It can, just because like they are no longer having such huge swings in intrathoracic pressure because they're tiring out. So that may happen, but it's one of those incidental findings where like you're going to know that they're about to crump from looking at all the other things in addition to the pulsus paradoxus.
Absolutely. We have started using, oh, where'd it go? We have started using CPAP with kids experiencing asthma. Do you have thoughts on this?
I think that that can be a great tool if it's something that is within your guys's scope and familiarity, because we've seen a lot of kids who that provides them just enough edge to not get not poop out from their work of breathing, and to help keep their airway open and maintain adequate gas exchange. And so it's something where usually in the PICU we'll do BiPAP because we have that option, but or we'll do mask CPAP just so that we're covering both their nose and mouth. But I think I think there's definitely a role for it, as long as people are comfortable using it and comfortable troubleshooting it.
Mhm. Here's a critical care transport question. Can you elaborate more on back-to-back albuterol, fluid boluses, high flow nasal cannula, and IM epi? In critical care transport, this is a normal day, but for some pre-hospital and critical access hospitals, it seems to be a much larger hurdle than it should be. And there was kind of a part of another question in there of how do you address with a critical access hospital when you think that the treatment for respiratory issues on that kid should be different than what they're providing?
So I think that it's important to recognize that everybody has like things that they're awesome at and they're comfortable with, and then like things where it's like stretched beyond what they're normally doing. And so like I have no idea what to do with an adult that's having a heart attack. It's been probably about 10 years since I've taken care of an adult patient, thank God. But I think like respecting our colleagues, and approaching everything in like the spirit of we're a team, we want what's best for the patient, can be huge. And sometimes it's just a matter of it's a matter of just, saying, hey, we'd love to be a resource. Let's check in and talk about how things are going. And sometimes people, they know the right thing to do and they know what the correct answer is on like a test, but they just need permission to do it in real life. Because if you're transporting a kid, you don't normally transport kids, the kid's wheezing, they look like crap, they're breathing hard, their heart rate has jumped up to like 180, 190 after that first neb, they look like shit, they've given them fluid, there can be a part of you that is like, okay, well, maybe what I was doing wasn't helping, or maybe or maybe I just need to wait to see if this works. And so sometimes it can just be offering that extra layer of support, and saying, yes, you know what you're doing, keep going. And then also, if you're dealing with like a referring hospital, having them talk through like what they're seeing, what their thoughts are, because a lot of times like people will often have like the knowledge base or like the inkling of the right thing to do. They just need the reassurance that they're on the right path. And then if you're like, oh, you're not on the right path at all, trying to figure out a tactful way to say it. Sometimes it can be like, sometimes I found doing X, Y, or Z can be helpful in this case. What would you think about trying that for that patient now? And if it's a situation where you're like, oh no, they are not doing the right thing and the kid is going to code, then you can be a bit more forceful, but just trying to partner with people I think is good. I don't know. That's kind of wishy-washy answer, but hopefully that answered your question.
Yeah, and it's so case by case too. And the nice thing is when you have relationships with those folks ahead of time, that seems to make it a lot easier than if you're coming in cold.
Yep.
Question, what are your thoughts on weight-based Solumedrol early in the field versus waiting for Decadron in the ED?
I think that like I think that that can be helpful if you're doing it for asthma, like we typically do like 1 to 2 mg per kg times 1 for severe asthma exacerbations. It's not something we typically do in croup, um, and so, you know, if you think that you really need that head start of half an hour to an hour in terms of your steroids to get them cooking, and it is something that your medical director or your protocols are okay with, go for it.
Nice, nice. In the state of Iowa, as we talked about, EMS providers aren't able to use CPAP or BiPAP on kids. Is high flow nasal cannula the next best option?
Yes, love high flow. So for high flow, if you can start it pretty low, and escalate it in a stepwise fashion up to 2 to 2.5 liters per minute per kilo, within reason, in order to offer support. It is something where, like, depending on the child, there are many kids that just because it's not covering as much of their face, they would actually tolerate that better than CPAP or BiPAP. And so it can be a very, very useful adjunct in terms of support to prevent a kid from decompensating further.
Can you give Solumedrol PO?
Think it's only an IV formulation.
Mhm. That would be a scope question as well. How many milliliters of air should we use for inflation of ET tubes for pediatrics? We do not have a way to measure cuff pressure.
Oh boy, that is a great question. So usually somewhere on like the little package that you get the tube out of, it'll usually say it'll say the capacity of the cuff. Also, when you're taking it out, also when you're taking the cuff out, taking the tube out and checking it to make sure that the cuff expands, you can get a sense of how much air like builds up most of the cuff. And sometimes when you're inflating the cuff, like, and you can have them bag at a pressure, have them bag at a higher pressure, and then just put enough air in it until you hear like the leak around the tube go away. Um, and so like, and so it's sort of like a Goldilocks answer. You need to put in enough, but not too much.
Yeah. Can you speak to what happens when there's too much?
What happens when there's too much is sometimes you can get pressure on the wall on the wall, the airway wall, and then that can lead to, in the short term, it can lead to worsening swelling later on, and then sometimes it can lead to like negative remodeling in terms of like later development of like subglottic stenosis, granulation tissue, but that's usually only for a long period of time. Like the most annoying thing is if you overinflate it and then you like burst the balloon and then you're having trouble like maintaining gas exchange because of the leak.
Mm-hmm. Here's a question from a different angle. Do you support having parents in the room during intubation?
I think that is totally dependent on the person doing the intubation. And so like when I'm having my first year fellows intubate, I will ask the parents to step out of the room or stay behind the curtain. If it is one of my senior fellows and they are comfortable with it and they think that it is important for the parents to see it happen in order to feel like their child is receiving all the care that they need, then that's okay. But usually, like, regardless, they need to stay far enough back that they're out of everybody's way. And if they start freaking out, we usually will have somebody assigned to help calm the parents down or shepherd them out of the room.
Yeah. Team CPAP or team BiPAP?
I'm team both. It depends on the indication and how you're giving it.
Mm-hmm.
But yeah, it's awesome adjuncts. I love them. So
With the American Heart Association releasing new changes in 2025, are you aware of any upcoming changes in the PALS protocol?
Ooh, that's a good question. I am
Mhm.
not, but I'm going to the AHA conference in a couple weeks. And so if I hear of any there, I will email Vicky and see if she can push them out.
Nice. Any tips for 911 providers who are working on a micro preemie born in the field?
Oh boy. Um, so, a full disclosure, I am not a neonatal person. Um, and all of the advice I can offer will be at least 10 years old. But same, it's going to be all the things that you would be doing. Making sure that you're having adequate gas exchange, making sure that you're keeping the baby warm, that is absolutely crucial. Also, their skin barrier isn't well developed. I would talk to your closest neonatal referral facility and ask them like, what are the key steps they want you guys to be able to do in order to stabilize the kids before they get there, before you get them to their final destination. But you know, just definitely keeping them warm. Monitoring them, which can be really challenging because they are so tiny. And then making sure you have a sense of like what their glucose is. Um, they aren't fully cooked, and so they have trouble maintaining homeostasis.
How do you feel about transporting in a Ziploc?
If that is something that that will help them maintain their body temperature, prevent excess loss of moisture from their skin, and is the most sterile and appropriate thing you have, and it's something that your medical director has said is reasonable, do it.
Yep, with their head out.
Oh, of course. Oh
Right.
gosh.
Well,
Yes.
yeah.
Mhm.
And I would add to that, be sure to transport them in an appropriate pediatric transport device for neonates.
Yeah. If
You have
an
to tag.
incubator can be really important to have. And these kids can lose their heat so much, just even like some of our older infants, just being transferred from one unit to another, or like going down for like a CT or MRI and coming back up, they can drop their temperature from being in the 37 range to like 34.
Very good. Is it a good idea to put end tidal on pediatric respiratory patients, or is it okay if it's tolerated?
If you're able to do that, that is incredibly awesome because and that can alert you to some problems. And so if you're talking about like end tidal when you are bag mask ventilating, end tidal if the patient is intubated, that can be huge. It lets you know your tube is still in good position, while you're bumping on along down the road. Also, it can give you a sense of like, how do you need to adjust the ventilator? In terms of neonates and micro and preemies, sometimes it can add a bit of dead space to the circuit. And I will talk to some of my neonatal colleagues and see what they would recommend. In terms of like, if you have an, I really don't think many, if any, transport teams have this, but if you have like side stream capnography for like a patient that like where you can deliver oxygen and also monitor the CO2 they're exhaling through their nose at the same time, that can be awesome because it can tell you like if you note like a lot of times kids will start to have like their CO2 rise before they become hypoxic.
Mhm. Is it beneficial to take a child with croup outside into cold air?
Um, I don't know of any evidence-based practices to do that. I know that cool mist is one thing that's recommended as a home thing, but I don't think that there is strong evidence on it doing it in the emergency department. I think that like whatever you can do that will help keep the kid calm, would be a huge priority.
Yeah, absolutely. Ooh, I'm reading all these good questions. Okay, let's couple more. Um, Is it common for pediatric patients to receive breathing treatments in the ER without further investigation of underlying causes? Like a
Um,
one-time respiratory thing.
it can be. So it sort of depends if and it's like there may be part of you that's like, okay, well, I want more of an answer, but if for example it's like late October, there is rhino entero going around the community. They've seen a ton of kids come in with either wheezing as part of the viral illness, um, and um, and the child has had an episode of wheezing with a previous viral illness. They may decide, okay, you responded well to the breathing treatment. This is most likely we took a history, and so we don't think that you have um, we don't think that there's any chance that you could have swallowed a ring or anything which could produce swallowed a foreign body. You've had symptoms consistent with a respiratory viral infection. And then it's like, yes, you could send the respiratory viral panel, you could get a chest x-ray, but then would it really change your management and how much more cost would that add for the family? And so if it's a kid, if it's a kid that's coming in with wheezing, who it was abrupt onset, they had been chewing on a crayon beforehand, and there's no family history of asthma or atopy, like that definitely deserves further workup and not being just like discharged home with like a script for albuterol. But it's sort of like you have to see the full clinical picture to say whether or not it's appropriate.
Yeah, very true. Perfect closing question. If you had one piece of advice for EMS providers caring for sick kids, what would it be?
It would be, oh, that's a good question.
Yeah.
It would be to, ooh, to trust trust your gut. If your spidey sense is telling you that something is wrong with the kid, start getting worried. The other thing would be have a healthy respect for how fast kids can crump. Kids can compensate pretty darn well, but there is a certain point where they're going to fall off a cliff. And that terms of falling off the cliff, in terms of like worsening respiratory distress and needing to be intubated, or like being in compensated shock to uncompensated shock, that can happen pretty dramatically. And so especially while you're figuring out like what disease you're dealing with, what's the tempo, it's just always good to have a high index of suspicion and always be asking yourself, okay, what are my next steps if stuff hits the fan?
We know those bad words.
Yes, yes.
Thank you so much. This was so much great information. Obviously, there's so much interest and underlying anxiety with regard to kids and respiratory problems. So we very much appreciate you being here and answering all the questions. You were very game. And we look forward to, the written materials that we'll send out to folks, answering all the questions so they can take a look at the videos. Thanks so much for your time. We appreciate you very much.
Yeah, thank you so much. And thanks for inviting me, and I look forward to listening to the other presentations.
Yeah, thank you.